My name is Art Krieg, and I've made this video to provide some of the history of cancer immunotherapy to people who are not immunologists. I've started a company named Zola Therapeutics to develop a new approach to cancer immunotherapy, so let me start with the story behind this name. Dr. William B. Coley was a surgeon more than a century ago when the only treatment available for cancer was surgery. A patient named Zola came to Dr. Coley in 1891 for treatment of this neck tumor, but the tumor was too advanced for Dr. Coley to operate. Several German doctors, Feilhazen and Busch, had previously reported that some inoperable tumors had regressed following bacterial infections, and Busch actually injected that type of bacteria into a patient's tumor and published that the tumor shrank. And so, with nothing else to offer Zola, Dr. Coley injected Zola's tumor with the same type of live bacteria. And what happened next was that Zola developed a high fever. He almost died from the bacterial infection. But within a few weeks, his tumor went away completely. And so Dr. Coley decided that for patients whose cancers could not be surgically resected, he would instead inject them with a killed extract of the bacteria that became known as Coley's toxins. And over the following decades, he treated more than 1,000 patients with advanced cancer with injections of killed bacteria, and in many documented cases, the tumors went away completely. Today, Coley is widely considered to be the father of cancer immunotherapy, even though in his day the immune system hadn't yet been discovered, and he had no idea that his bacterial extract was activating the immune system and inducing what we now call CD8 positive T cells, which can effectively kill tumors. Unfortunately, the bacterial preparations were very inconsistent. Some other doctors never had any success with them. And by the mid-1900s, Coley's toxins had been largely abandoned. Coley's approach to treating cancer lives on in the treatment of bladder cancer with BCG, a well-established and effective bacterial treatment. No one is really sure exactly how BCG works, but about 40 years ago, a group of Japanese investigators reported that the active ingredient in BCG is the bacterial DNA, its genetic material. This was unexpected, but they went on to treat 68 patients who had various skin cancers with a preparation of BCG DNA that caused about 40% of these tumors to shrink. This was very intriguing, but the DNA preparation was difficult to characterize, and the treatment didn't get approved. Now, about 10 years after that report, while I was working on something completely different, I accidentally discovered that immune cells detect CpG in foreign DNA. CpG stands for cytosine phosphate guanine. And in our DNA, these are methylated with a methyl group, CH3. But in bacterial or viral DNA, CpG is unmethylated. And hundreds of millions of years ago, life evolved a specific receptor to detect unmethylated CpG DNA based on this simple structural difference. This receptor is called toll-like receptor 9, or TLR9. And when it detects this unmethylated CpG DNA, it's like a danger signal for the immune system. And TLR9 activates immune defenses, including CD8 positive T cells, which have a unique ability to kill infected cells in our body, and they can also be harnessed to kill tumor cells. And so, almost 30 years ago, I started my first biotech company called Coley Pharmaceutical Group to honor Dr. Coley. And we and others tried to treat cancer using a form of modified synthetic CpG DNA called CpGB and CpGC. And this treatment caused some responses in small skin cancers and some lymphomas. But 3 large randomized clinical trials run by Pfizer and other companies in more advanced tumors showed no benefits to patients, and so those programs were terminated. Very disappointing. But our research showed a much stronger immune stimulation using a different form of DNA called cpGA, which has a natural structure that is a much better mimic of foreign DNA than the CpGB and C forms. And so 10 years ago, I started another biotech company named Checkmate Pharmaceuticals because we hoped to checkmate the tumors. And this patient is one of the first who received this treatment, now called vidutolimod. This 48-year-old woman had advanced melanoma that progressed through multiple prior therapies listed on the left. Her tumors just kept growing and spreading, as you can see in this scan of her lungs. She enrolled in our clinical trial, and her doctor injected a single metastasis that was in her groin, far away from these lung tumors, with vidutolimod. And after several months of this form of CpG DNA treatment, she had a systemic response. The lung metastases went away. As far as I know, it didn't come back. And she is just one of the responders in these clinical trials. Of 98 patients with advanced refractory melanoma, where standard checkpoint inhibitors had failed to stop the tumor, the addition of vidutolimod shrank the tumors in 27 patients. About a quarter of the patients responded, and these responses lasted for an average of more than 2 years. 40 patients were treated with vidutolimod alone, and almost a quarter of these patients also responded, but for a shorter duration of time. And in patients with earlier stage tumors, the success rate was even higher. More than half had what's called a major pathologic response, and in a randomized trial of 57 patients, the addition of vidutolimod to a checkpoint inhibitor improved the major pathologic response rate by 20%, with no major change in the safety profile. And so this is great news for the patients who responded, and my company, Checkmate, was acquired by Regeneron about 3 years ago. But following that transition, I kept coming back to this question of why didn't vidutolimod work in more patients? And so to explain what I think is the answer to this question and why I decided to start Zola Therapeutics last year, I want to dive deeper into how the immune system works, starting with how does it detect infections. Infectious pathogens have molecular structures that are different from the structures in our own bodies. Bacterial capsules have a variety of unique structures in addition to their CpG DNA. Viruses are harder to detect, but our immune cells can detect the CpG DNA, and they can also detect subtle differences in the structures of viral RNA. There are other molecules that our immune cells can detect in parasites and yeast. Our immune cells detect these various structures using dozens of different pattern recognition receptors, or PRRs, some of which are shown in this figure on the left, that shows the complexity of this system. It's poorly understood exactly how all of these different PRRs can sense what is going on in our body. But we know that TLR7 and TLR8, in the green box down here, detect foreign RNA. TLR9 detects foreign DNA. And there are also PRRs that detect damage in our cells. We now know that there are dozens of types of immune cells, and each of these make a few of these pattern recognition receptors. None of them express all of the PRRs. And somehow, these receptors allow the immune cells to taste different types of danger and to figure out what's going on in the body by communicating with each other. The three main flavors of danger that these receptors and immune cells have to distinguish are, first, intracellular infections, viruses or retroviruses infecting a cell in our body, and that infected cell has to be killed, and CD8 positive T cells evolved to do this. Second is extracellular infections, think bacteria or parasites, that need to be killed outside of the cells in our body. And finally, we can have trauma without infection, in which case the various immune cells that are attracted into this damaged tissue need to promote healing. So in the case of an intracellular infection, like a new virus or retrovirus, the only way to detect the infection is through the foreign RNA, which can be detected through TLR7 or TLR8, and the viral DNA that's detected through TLR9. These receptors for the viral RNA and DNA are present in some very specialized immune cells called dendritic cells, macrophages, and B cells, but not in the T cells. These TLRs respond to the presence of the foreign RNA and DNA by activating these immune cells to make interferon alpha, which is a critical factor to induce new populations of CD8 positive T cells that act like assassins. They are uniquely able to kill infected cells without killing the uninfected cells. And of course, this is the response that we want to trigger to treat cancer. And so maybe you can see where I'm going with this. cpgDNA is only one of the signals to trigger these cells. The viral RNA is another key signal that the immune system evolved to use to activate CD8 positive T cells. And I'll come back to that. Extracellular infections are detected by the unique patterns of those pathogens, and the immune cells in our body then focus on a different kind of response to kill those pathogens outside of our own cells. And finally, if there's no infection, damaged cells or stress cells in our body release damage molecules and small blebs from the cells that tell the immune cells to help the tissue to heal. They stimulate what's called angiogenesis, which is the formation of new blood vessels to bring more nutrients. Tumors actively release damage molecules. They mimic damage, and they trick the immune cells into helping the tumor grow. Because of this, it's been said that tumors are addicted to death. One way to treat cancer is to block these death signals, and that can free the immune system to attack the tumor. A more direct way to treat cancer is to activate the immune system to make CD8 positive T cells when immune cells detect these signals of viral infection. So if we provide the immune cells with synthetic mimics of RNA and DNA, that should be all the system needs. This idea is at the heart of my new understanding of why cpgDNA alone doesn't cure more tumors. So let's turn to the types of immune cells that are actually in human tumors, and which of these can detect the viral RNA and DNA signals. Scientists have come up with incredibly powerful methods to identify and characterize individual immune cells in a tumor. Each dot here represents a single immune cell in one patient's tumor, and they've been color-coded based on their general subset, but the details don't really matter. The key point is that we know there are a lot of immune cell types in most tumors, and we know that since the tumor is growing, these must overall be helping the tumor rather than attacking it. Of all these different types of immune cells in the tumor, only the yellow cells express the TLR9 that allows them to detect cpgDNA in vidutolimod. The other cells think that there is no infection because they're not activated, so they keep trying to protect the tumor, even as these yellow cells are sounding the alarm and trying to attack the tumor. It's easy now to understand why vidutolimod didn't work in more patients when so few of the immune cells in the tumor are actually being activated. These other populations of immune cells that can't detect cpgDNA can instead detect the viral RNA. Some of them express TLR7 in red, others express TLR8 in blue, and a few express both of the receptors in yellow in the right panel. Many immunologists now believe that immune cells in the tumor use crowd wisdom to decide if a tissue is infected or only damaged. That is, different subsets of the immune cells in the tumor detect different parts of a pathogen, and they vote on whether the tissue is infected or only damaged and what to do. So, to improve cancer immunotherapy beyond what we achieved with just activating TLR9, we need to add a foreign RNA mimic to the cpgDNA to activate all of these cells to stimulate a CD8 T cell response that can attack the tumor as if it were a viral infection and without harming normal tissue. And that's why I decided to found Zola Therapeutics and why we're developing Z007, the world's first TLR7, 8, 9 triple activator, mimicking viral RNA and DNA structures based on everything we've learned over the last 30 years of research on these receptors and pathways. Compared to vidutolimod, Z007 activated immune cells to make more than 50 times more of the interferon alpha that's needed to activate the CD8 positive T cells, without stimulating harmful inflammatory responses that have been triggered by many other therapies in clinical trials. And we saw this powerful effect not only in normal human immune cells, but also in human tumor-associated immune cells and in monkeys with an IV infusion that activated immune cells in the blood, liver, lymph nodes, and spleen. In mouse tumor models, we see the tumors shrinking, so we're very encouraged by these results, and we think Z007 could be a powerful drug for helping humans with cancer by activating their immune cells to generate new CD8 positive T cells to fight the tumors more effectively than prior treatments. So, to summarize the state of the art today, cancer immunotherapy is mostly focused on CD8 positive T cells. One approach is exogenous, where large numbers of CD8 positive T cells from an individual patient's tumor or blood are grown outside the body and then reinfused into the patient. Examples are CAR T or TIL therapies, which can be very effective against some tumors, but they're expensive and the treatment is often pretty toxic. For patients who already have T cells in their tumors, these can be directed against the tumor using checkpoint inhibitors or therapies called T cell engagers or a variety of different antibody therapies. There's still a big need for treatments that will activate new CD8 positive T cells against the tumor by activating PRRs. And despite many failures where the response rate to the treatment by itself in refractory tumors was less than 10%, there are several approaches today that look encouraging with response rates above 20%. Including, for example, some mRNA therapies, the CpGA in vidutolimod, and live viruses that are engineered to infect tumors. These are called oncolytic viruses. Based on the data we've generated in mice, monkeys, and in human cells, including cells associated with human tumors, I expect Z007 to have a better response rate and safety profile than we have seen before. Z007 uses a lipid nanoparticle for delivery, which avoids a problem with neutralizing antibody responses to the virus-based approaches. And this enables Z007 to be given IV with increased uptake in tumor-associated immune cells throughout the body. We won't know how effective Z007 will be until we test it in human clinical trials, and I hope these will begin next year. Stay tuned for more updates on this. I think the future therapies for patients with cancer will continue to improve.